thank you guys so much for joining. Welcome. And thank you for the introduction, Shelby. So tonight is more of Fertility 101, kind of an overview of what's involved in fertility, different treatment options. So hopefully it's helpful. Hopefully you take away some good knowledge points and learn some information. I usually say the hardest part is making that first appointment, always, because you've kind of delayed it and you've thought about it. So hopefully at the end of this conversation, if you want more information, you can make an appointment. But usually the first consult, making that appointment, is the hardest step. Once you make that appointment, then we'll go through your history, kind of rediscuss what I'm going to discuss that's applicable specifically to you and different treatment options. So why would you see a fertility specialist or an REI? So I have some patients that self-refer them, or I have some patients that come through an OBGYN. Either is possible and welcome. So usually we would say a person meets the diagnosis of infertility if they've been trying for a year without success, if they're under 35, and 6 months over 35. And I'll talk a little bit later on about why we shorten that time frame when we kind of get over 35 years old. Also, if, for instance, somebody has irregular cycles, you do not need to wait a full year of trying if you're not having menstrual cycles, because that also means you're not ovulating. So if you have known fertility issues, like somebody has previously told you one of your tubes was blocked, or your partner did a semen analysis and the sperm count was low, or you had irregular cycles, those would be reasons to see us. The other patient population that we see a lot of besides infertility patients is recurrent pregnancy loss patients. So people that have had more than one miscarriage. And then the final kind of also a group of patients that we see is patients that decide to freeze either eggs, sperm, or embryos for future use. So the way I usually break down fertility to make it make sense in my mind is I think of all of the structures involved in fertility and how do we kind of go through each one and figure out, okay, is that structure functioning or is that contributing to the problem? And that also dictates kind of which treatment route we go. So thinking from the male counterpart, so that's an easy check. It's a semen analysis to look at the sperm. From the female part, we're talking about the ovaries, the uterus, the fallopian tubes. And part of this kind of initial consult, or the first half of the consult, is just going through your history, right? So any prior pregnancies. Were any of those prior pregnancies complicated? Did you have miscarriages? Because that feeds into kind of how we can prepare you for a successful pregnancy, because we want you to get pregnant, but the goal is a healthy full-term, baby and a healthy mom. Also going through your GYN history. So cycle history is super important. So just based on your cycles, we can get an idea of whether you're releasing an egg or not. From your medical history, we can also get an idea if we think maybe one of the fallopian tubes is an issue, if you've had surgery before in your pelvis, or if you have known endometriosis. Medical history also, if you have chronic medical problems like chronic hypertension or diabetes, but most definitely does not preclude you from, getting pregnant. But we also want to make sure your health is optimally controlled for kind of that healthy pregnancy. So that involves kind of going through the history, making sure all of the medical problems are as optimized as possible. And part of that assessment involves just sending prenatal labs. So if you got pregnant on your own and you went to your OB and you had a big panel of blood drawn, that we actually do in advance. So it's going to check things like blood type, whether you're still immune to chickenpox, your vitamin D. Everyone's vitamin D is low. We have been in quarantine and now we're in the summer and it's too hot to be outside. So we're all vitamin D deficient. Thyroid's super important for brain development in the fetus, and too low or too high can be abnormal. And then genetic carrier screening is also super important. So a lot of our genetic diseases are recessive diseases, meaning in order to get the disease, I have to inherit one mutation from my mom and one from my dad. If I just inherited one mutation from my mom, but inherited a normal allele from my dad, I'm a carrier for that condition. I do not have the disease. Nobody would ever know. An example of this would be cystic fibrosis or sickle cell. But if I am a carrier for the same disease that my partner is a carrier for, then the child could have the disease. So it's helpful to know if I'm a carrier for any genetic diseases, because there's actually something that we can do about it now. So I'm usually biased, so I always start at the ovary. So looking at somebody's cycle history can give us an idea if somebody is ovulating or not. So if somebody has regular cycles would be 21 to 35 days, and it doesn't vary more than 3 days. Then the majority of those cases are releasing an egg. Now, if you're not releasing an egg, the most common cause, at least in the United States, for that is something called polycystic ovary syndrome. And that requires a kind of additional lab work to make that diagnosis and to work it out. So that's part of the ovary assessment. Are we ovulating? The second kind of ovary assessment is something we call ovarian reserve, which is really an estimated remaining egg count. Why do we care about that? Well, every month, it's like our ovaries kind of open the door and release a group of follicles on each side. These follicles are fluid-filled sacs, so they're like cysts, but we don't call them cysts because they're small. They're less than a centimeter. And in each one is a microscopic egg. Through very complex mechanisms, one follicle grows to be about 2 to 3 centimeters, and then mid-cycle, it ruptures and you ovulate or release your egg. The rest of the follicles actually undergo cell death, and the next month, you get kind of a new group of follicles that get pushed out. The one big difference between women and men is that men can make new sperm. They have these special germ cells, but unfortunately, we as women cannot make new eggs. So our egg count kind of since puberty slowly declines, and then a little bit more rapidly declines in our mid to late 30s. So getting an assessment of where we are egg count wise is helpful to see if that may be contributing to the infertility, and also helps us determine what treatment may be beneficial and dosing of medication. And that's why when we define infertility, we shorten that period to 6 months over 35, because we're taking into account that more rapid ovarian reserve decline. So to get an idea of our egg count, AMH is one of those hormones along with FSH that gives us an idea of where we are ovarian reserve. It is a number, so I can tell you your egg count is appropriate for your age, above average or below average. I'll never be able to give you a specific amount. Like Ms. Smith, you have 2,032 eggs left and you're hashtagging every month. No, I can't do that. But I can at least say, hey, for a 32-year-old, your egg count is appropriate for your age, above average or below average. And I probably place the most weight on the AMH. It's a hormone made by the cells around the egg. So the more eggs you have, the higher the AMH. The ultrasound is also helpful. You can see here on the left, this is a picture of an ovary, and these are the little follicles that I was telling you about. So in each one is a microscopic egg. The follicle count we can also use as an opportunity to kind of get an egg count assessment. It's also used as part of the criteria for the PCOS or polycystic ovary diagnosis. The ultrasound will also give us an idea of what's happening in the uterus. Now, there can be a uterine cause for fertility, It's not as common as male factor or ovarian factor, but for instance, somebody that has fibroids or somebody that has scar tissue in the uterus. So sometimes we can get an idea of that just based on someone's history, but the basic ultrasound that we do will at least give us a starting point overview for the uterus. So what I say is after the consult, we actually have you come in on your period. Why? Because that's when we're going to get an accurate assessment of the follicle counts and your hormones. So when you come in on your period is when we tend to send your prenatal labs, we do the ultrasound, and we get the hormone assessment. Okay, so it's a fair amount of blood work. You do not have to be fasting. And then we usually then schedule you for the tubal assessment, okay? So at that first visit, when we do the blood work and ultrasound on your period, we get an idea of overall health, egg count, a little bit on the outside of the uterus. And then the last structures on the female side would be to check the fallopian tubes and the inside of the uterus. So there's two ways that we will commonly check the tubes. One way is called the HSG. So you're awake for this procedure. So that's one really nice thing about this procedure. You can drive yourself to and from. Nobody has to be with you. We take a small catheter and we insert it through the cervix into the uterus, and then we inject dye. Go back. So this is the shape of the uterus. It's kind of like the inside of a triangle upside down. And you can see this is one fallopian tube filling and dye coming out here. This is the other fallopian tube filling and dye coming out here. So in this image, this is a normal HSG. The limitations of the HSG is that you're awake, so it can be a little uncomfortable. If we see something abnormal since you're awake, we can't fix anything, okay? Another option is a hysteroscopy, okay? So a hysteroscopy is where we take a camera about the size of my pen and go through the cervix and into the uterus. So the nice thing about this is I'm actually looking with my own eyes on the inside of your uterus. I can fix things while I'm there. So if there were scar tissue, if there were fibroids, if there were polyps, I can also inject dye into each tube and even fix a tubal blockage right where the tube meets the uterus. The downsides for this, you have to go to sleep, but it's outpatient surgery. So there's no incisions on your belly. You go home the same day. So really, we can do the workup on the female side in the visit that you come in on your period for the blood work and the ultrasound and the tubal check. So you can kind of think of that first month as a testing month. And then you follow up to review the results. At any point during that month, while you're doing the testing, your partner can do a semen analysis. So that is easy because each office, and we have many different locations across Houston to make it convenient, has certain days that we do the semen analysis. You can collect in the specimen room or collect at home and bring it in. And we're looking at a couple things on the sperm. We're looking at count. So how many sperm do we have? We're looking at how many are moving or percent motile. What is the shape of the sperm? So you can see a picture of normal shaped sperm and abnormal shaped sperm on the screen. So is the head small? Is the head normal shaped? Is there a bent tail? Is there two tails? And that gives us at least an initial assessment of the sperm. So at that follow-up visit, we'll really kind of put together what the reason is for infertility. So is it a sperm issue? Is one of the tubes blocked or both tubes blocked? Is it an issue ovulating? Is our egg count low? Or does everything look normal? And then you kind of fall into the unexplained infertility, which sometimes can be frustrating because you don't have a reason. And that's about 20% of patients, but be reassured that we treat it the same way. The success rates are just as good, okay? So depending upon the reason for the infertility, it may dictate one treatment over the other. And in some situations, such as unexplained, both treatment kind of options may be available. So I usually group the treatment options into ovulation induction, which includes timed intercourse and intrauterine insemination, and then IVF or in vitro fertilization. So starting at timed intercourse or IUI. So the idea of this type of cycle is to get people to ovulate who don't normally ovulate, to maybe increase our odds a little bit by making more than one egg, but not too many eggs, to time the egg release with sperm exposure, and if we're doing the intrauterine insemination, to get the sperm closer to the egg. So usually we pair this cycle with oral medications like Clomid or Letrozole, and you take that for about 5 days, and then you come in for monitoring visits where we are essentially measuring the follicles in the ovary. So remember, if you think back to that very first ultrasound picture, you had those tiny small follicles. So that goal of this is to get those follicles to grow, maybe 2 or 3, but not much more than that, because the goal is not to have your own TV show for triplets, quads, quints. So ideally a couple follicles, and then we time the ovulation with what we call a trigger shot. And then we either have you have intercourse for the next couple days, or you can see the picture on the right, we inject the sperm inside the uterus. So the sperm have a much shorter pathway to get to the egg. And then 2 weeks later is your pregnancy test. So that's kind of the IUI overview. So for this to be a, an ideal option, we at least need one fallopian tube open. We need enough sperm. We also need, an appropriate egg count. So that would be the timed intercourse or IUI option. IVF, different goal, right? So for this, when you think back to that original picture with all the small different follicles, remember in the IUI or timed intercourse, we only want a couple to grow. In IVF, we actually want all of those follicles to grow. So it's not all of the eggs you have, it's just the eggs that are there already that month. We're just getting all of them to grow, not just the one that you would normally grow and release. And we do that through injection medications. So this is when you do injections. You would have a nursing visit where they specifically go over how to do the injections. They are tiny needles that you give yourself in the belly. Even people that are petrified of needles can do this, trust me. And the injections are directly stimulating the ovaries. So the goal is to get all of those follicles to grow, and we monitor you very closely during that time period. The average time is about 12 days for injections at our clinic. Once those follicles get big enough, then we trigger your ovulation. But this time, before you release the eggs, we actually go in and aspirate them. So in the middle photo, you can see the needle kind of being placed into the follicle. So we pull off those eggs, right? And you can see the egg in the top left photo. That same day, we're either using donor sperm or partner sperm. We inject one sperm in each egg. So it's called ICSI. We used to, years ago, do traditional IVF where they would just put the sperm in a dish with eggs and come back and see which one correctly fertilized. But nowadays we do ICSI on everybody, meaning we inject the sperm into the egg, which helps decrease the number of failed fertilization cycles. The next day, we have day 1 embryos. So we know at that time how many eggs and sperm correctly combine to form an embryo. And then this is when we culture the embryos out in the lab. So this is what our embryologists do so well, because it's very hard to culture embryos, and our lab does a fabulous job at getting healthy embryos. So they grow these embryos out in the lab till the bottom right box. And on day 5 or day 6, we have a blastocyst. So this embryo is made up of hundreds of cells, and we have the ability to genetically screen that embryo. Or we can transfer it. Now, I will say most of our transfers are frozen, meaning whether we're doing the testing or not, we tend to freeze the embryo at this stage, let your body kind of reset itself, and then transfer because of improved success rates. So the genetic testing. So I talked about the genetic testing at the very, very beginning, but that was regarding the carrier screening on yourself, right? This is genetic testing or screening on the embryo. So there's two things. There's genetic screening, which we used to call PGS. Now we call PGTA. So just to be confusing, things were renamed. So it's pre-implantation genetic testing for aneuploidy, meaning chromosomal abnormality. So this testing, it is not sequencing the embryo. We are solely saying are the correct number of chromosomes there. So it's going to pick up any extra chromosomes, missing chromosomes, and gender. So it's going to pick up on things like Down syndrome. So that when you put the embryo back inside the uterus, your success rate is quite high because you've taken away the #1 cause of failed cycles or miscarriages, which is going to be a chromosomal abnormality. So that's PGTA. There is also the option of PGTM, which used to be called PGD. So if you and your partner are carriers for the same condition, like let's take cystic fibrosis, then we actually have the ability to do IVF, genetically screen that embryo for the mutation, and pick embryos that do not have the disease. So, which is actually pretty amazing because you can really eliminate transmission of diseases that are pretty catastrophic. So we do get patients that don't necessarily have infertility, but maybe, have had a child born with cystic fibrosis or sickle cell, and they want to have a second child, but avoid disease transmission. And that's a way of avoiding that.